In 1879, a British missionary doctor stood in a hut in the Kingdom of Bunyoro, in what is now Uganda, and watched something that should not have been possible according to everything he had been taught about Africa. He watched a team of African surgeons perform a Caesarean section. The mother was given banana wine as anesthesia. The surgical team washed their hands and the patient's abdomen with the same wine before cutting, an antiseptic technique that European surgeons would not standardize for another several years. They made a vertical incision, controlled the bleeding using cautery, removed the baby, and then closed the wound using sharpened iron needles and plant fiber thread in a technique that promoted healing and prevented infection. The mother survived. The baby survived. The surgical team had clearly performed this procedure before. Their movements were practiced, confident, and methodical. The doctor's name was Robert William Felkin. He documented everything he saw in careful medical detail, and his account was published in the Edinburgh Medical Journal in 1884. It remains one of the most important documents in the history of African medicine, because it captured something that the dominant narrative of history insists could not have existed. Sophisticated African surgical practice, witnessed firsthand by a trained European physician, performed with techniques that were, in some respects, ahead of what was standard in Europe at the time. This is the story of African surgery, and it does not begin in 1879. It begins thousands of years earlier, in the Nile Valley, with a document that rewrote what historians thought they knew about the origins of medicine. The Edwin Smith Papyrus is the oldest known surgical text in human history. The copy that survives dates to approximately 1600 BCE, but scholars believe it was copied from a much older source, possibly dating back to 3000 BCE. It is named after the American antiquities dealer who acquired it in 1862, but the knowledge inside it belongs entirely to ancient Egyptian medicine. The papyrus contains 48 case studies, each structured with remarkable clinical precision. Each case presents an examination, a diagnosis, a prognosis, and a treatment plan. This is not a list of magical incantations or superstitious remedies. This is a clinical methodology that would be recognizable to any modern physician. The cases cover traumatic injuries in extraordinary detail, wounds to the head, the neck, the spine, the chest. The papyrus contains the first known description of the cranial sutures, the meninges, the surface of the brain, and the cerebrospinal fluid. It contains the first recorded use of the word brain in any human language. It describes how to assess and treat spinal cord injuries with an understanding of the connection between specific vertebrae and resulting paralysis that would not be matched in European medicine for thousands of years. The treatments described include wound closure using adhesive strips, the use of honey as an antibacterial dressing, a practice modern medicine has returned to because honey genuinely does have antibacterial properties, and splinting techniques for fractures that remain fundamentally similar to methods used today. This was not primitive trial and error. This was systematic, documented, transmittable medical knowledge. And surgery in ancient Egypt extended beyond trauma care. Archaeological evidence shows that ancient Egyptian surgeons performed trepanation, a procedure involving drilling or scraping a hole into the skull, typically to relieve pressure from injury or to treat conditions believed at the time to require it. Skulls have been recovered showing clear evidence of bone regrowth around the trepanation site, which means the patient survived the procedure and lived long enough afterward for the bone to heal. This tells us two critical things. The surgery itself was performed with enough skill and care to allow survival, and the post-operative care was sufficient to prevent fatal infection in an era without modern antiseptics. Egyptian surgical tools have also survived. bronze and copper scalpels, hooks, forceps, and probes, some displayed today in museums, all demonstrating a level of instrument specialization that indicates surgery was a defined, practiced medical specialty, not an improvised emergency measure. This tradition of surgical knowledge did not stay confined to the Nile Valley. Across the African continent, distinct surgical traditions developed independently, adapted to local conditions, local diseases, and local available materials. Bone-setting practices across West Africa developed sophisticated techniques for fracture reduction and immobilization, using materials like raffia, bamboo splints, and herbal preparations that modern researchers have studied for their anti-inflammatory properties. Traditional bone setters in Nigeria and Ghana continue to treat fractures today, and several modern medical studies have found their outcomes comparable to conventional orthopedic treatment for certain types of fractures. A finding that surprises Western-trained physicians specifically because they have been taught to assume the techniques must be inferior. And in East Africa, the surgical tradition that Robert Felkin documented in Banyoro was not an isolated miracle. Surgical historians who have studied his account note that the technique he described, including the use of cautery to control bleeding, the sequence of incision and closure, and the postoperative care, reflects an established surgical practice refined over generations, not an improvised one-time event. Felkin's account specifically noted that the operating surgeon directed his assistants with calm authority throughout the procedure, that the instruments were prepared in advance, and that the entire team appeared to be following a known and rehearsed protocol. This was not the first Caesarean section this surgical team had performed. It was simply the first one a European had been present to document. Consider the timeline. Felkin witnessed this procedure in 1879. At that time, Caesarean sections in European hospitals carried an extremely high maternal mortality rate, infection control was not yet standardized, and the procedure was generally considered a last resort, performed only when the mother's death was otherwise imminent, and even then, often resulting in the mother's death from infection or blood loss shortly afterward. The Banyoro surgical team, Felkin observed, had a living mother and a living child, achieved through techniques including herbal anesthesia, antiseptic washing, and a closure method designed specifically to promote healing. This is not a story about Africa catching up to European medicine. In this specific documented instance, African surgical practice was, by the measurable outcome of patient survival, ahead of contemporary European practice. So why don't you know this? The answer is the same answer that applies to every video on this channel. The dominant narrative of African history was constructed by people who needed Africa to be without sophistication, without science, without medicine, in order to justify what colonialism was doing to the continent. A functioning, successful, technically impressive African surgical tradition was incompatible with that narrative. So it was minimized, dismissed as anecdotal, or simply left out of the medical history books that were being written in Europe at the same time these very practices were being documented by European witnesses. Felkin's own account survived because he was a credentialed physician whose word carried institutional weight. Countless other instances of African medical sophistication were witnessed by people whose accounts were never published, never taken seriously, or actively suppressed because they contradicted the colonial project's foundational assumptions. The history of surgery taught in most medical schools begins with ancient Greece, with Hippocrates, with Galen, and proceeds through European medical history with Africa, appearing only as a site of disease to be treated by European doctors, never as a source of surgical knowledge in its own right. That history is incomplete. The Edwin Smith Papyrus predates Hippocrates by well over 1,000 years. The Banyoro surgical team's technique in 1879 was, in measurable outcomes, ahead of what was standard in European hospitals at the same moment in history. Your ancestors were performing successful Caesarean sections with anesthesia and antiseptic technique, while it was still common practice in European medicine to operate without washing your hands. Your ancestors wrote the first medical description of the human brain on a papyrus scroll 1,000 years before the Greeks had a word for the organ. Your ancestors set bones, performed cranial surgery, and developed antibacterial wound treatments that modern medicine independently rediscovered thousands of years later. This was not folklore. This was medicine. Documented, systematic, transmitted across generations, and effective enough to save lives in conditions that should have made survival impossible. The next time someone suggests that modern medicine is a uniquely European achievement, remember a hut in Banyoro in 1879, a mother who survived, a child who survived, and a British doctor standing in stunned silence, watching African surgeons do something he had been taught Africans could not do. They had been doing it for generations. He was simply the first European in the room to write it down.